to you about management of heavy menstrual bleeding. Dr. Human attended the medical school at the University of Nebraska. She completed her residency in obstetrics and gynecology at Nebraska Medical Center, and then did her pediatric and adolescent gynecology fellowship at Tufts Medical Center in Boston. She joined our group in Norton Pediatric and Adolescent Gynecology in the fall of 2020. Her clinical interests include managing heavy menstrual bleeding, complex contraception, and prepubertal vulvovaginitis. She has published articles on these topics, and today will speak to us about management of heavy menstrual bleeding. Thank you, Kim.
Thank you, Dr. Hertwick, and good morning, everybody. I'm going to switch over, get my screen shared so that we can get our topic going. So just as Dr. Hertwick mentioned, today I'm going to talk about the management of heavy menstrual bleeding. I have no disclosures. And so we're going to start with a question, just similar to what we did with Dr. Dwiggins. So this is a 13-year-old female with irregular and heavy periods. Menarche started 6 months ago. She has a period every 1 to 1.5 months, lasting 7 to 8 days. Heavy flow on days 2 to 4, changing a pad every 5 to 6 times a day. There's no overflow onto the bed sheets at night. She'll pass dime-sized clots. Denies any nosebleeds or excessive bleeding at the dentist. There is no family history of bleeding disorders. She is otherwise healthy and active in soccer. She takes no medications. Her blood pressure is 110/73 with a heart rate of 92 in the office. And what would then be the most appropriate first-line labs to order in this patient? I'll give you a moment to look at those choices. And then we can display the answers once we feel like we've got enough participation. Okay, so 60% of people chose option A, and we'll go to the next slide. I apologize. And so option A was the correct answer. And by the end of this talk, you should have a better understanding as to why this is the correct response and when a more extensive workup would be indicated. So let's do our roadmap of what we're going to learn today. We're going to learn about the typical pubertal development, how to assess menstrual heaviness, and then we're going to talk about treatment options, hormonal and non-hormonal. So to start off, we'll talk about pubertal development. The pubertal progression begins between the age of 8 and 13. It starts with the growth spurt, and then you have pubic hair and breast development, and then menarche starts about 2 years after breast development starts. And normal periods after menarche for adolescents, is a bit different than what you'd expect for an adult. And Dr. Dwiggins had mentioned this in her presentation, but it's common for periods to occur about every 21 to 45 days. Bleeding should be 7 days or less. They should be using 6 pads or 4 super tampons a day or less. And then it's normal to have some mild cramping. So how do we assess the menstrual heaviness? So how do we know if it's too heavy? Well, if they're saturating more than 6 pads or more than 4 super tampons in a day, or changing every 2 to 3 hours, that would be a bit too heavy. It is also important to note that when you're asking about how many pads or tampons the child's using, that we should ask about how saturated the pads and tampons are, because it's common for adolescents to change frequently for hygiene reasons. So what I typically ask when they're using pads is, what percent full do they think that pad is? And I say side to side, front to back, completely covered in blood would be 100%. About how full is your pad when you change it? And then if they're changing their pad 5 to 6 times a day and it's nearly fully saturated, that's too heavy. If they're changing it that often and they're saying it's only 20 to 25% full, then that gives me a better idea of exactly how much bleeding they're having. I do ask if they're passing clots, and greater than an inch would be considered too heavy. Do they flood or have overflow at night onto their bed sheets? And then I also, sometimes they'll say that they have it onto their clothes, and I'll then assess, is it because the pad shifted or you were in a, what position, it was position related while you were sleeping, or is it because the pad is mostly full and then it's overflowing onto your clothes because there's no more absorption left in the pad. And then lastly, signs of anemia, lightheaded, dizzy, short of breath, especially when they're on their period. And one of the most common reasons why adolescents will have heavy periods is because they're having anovulatory periods. And this is due to the immature HPO, which is the hypothalamic pituitary ovarian axis. And it's because this is a progesterone deficient and estrogen dominant state. So they're not ovulating an egg every month from their ovary. And so when they bleed, it's more because the lining is outgrowing the blood supply and it's more of an estrogen dominant run system. This is the reason why you have cycles that are every 21 to 45 days, and they might be a little bit heavier and might last a little bit longer than usual. This is very common the first 3 to 5 years after periods start. And by the 3 year mark, about 95% of cycles are ovulatory, which then makes them a little bit more regular, shorter, a little lighter if the heaviness was due to anovulatory periods. There is an inverse relationship with becoming ovulatory to time of menarche, meaning if you have menarche at an earlier age, there's a shorter time to ovulatory cycles. Whereas if you have menarche at a later age, that it might take a little bit longer for the cycles to become ovulatory. So when having irregular, prolonged, and heavy bleeding, it would be more likely to be due to anovulatory periods. If they come in and they're having regular and heavy bleeding, that might be more consistent with a bleeding disorder. And bleeding disorders are seen in about 20% of those with heavy menses. Von Willebrand disease is one of the most common inherited bleeding disorders among American women, with a prevalence of 1 to 2%. Up to 25% of those that have chronic heavy menstrual bleeding will have von Willebrand disease. So how do we screen for a bleeding disorder? One or more of the following items should raise a red flag that maybe we should look at ordering labs to rule out a bleeding disorder. So periods lasting longer than 7 days associated with flooding or gushing or bleeding through a pad or tampon within 2 hours, a history of anemia, a family history of a bleeding disorder, or the patient has known excessive bleeding after surgery or dental procedures. So let's go into the workup. So a basic workup, you get your history, their physical exam, assess their vital signs. If through all of that information, you don't have any concerns about anemia or bleeding disorder, the basic workup would be a CBC, a ferritin, and a TSH. An extensive workup would be for a patient that you're concerned about a bleeding disorder or anemia, or that CBC returns and they do have anemia. And I would state that if your hemoglobin's under 10, that would then be an indication that they're bleeding too much and we should be ordering bleeding disorder labs. And so bleeding disorder labs would then be the coags and von Willebrand panel. It's also reasonable at this time or when the labs return to consult hematology for co-management if a bleeding disorder is diagnosed, or if all of these labs return normal and we still don't have a great explanation as to why they're bleeding so heavily and why they're so anemic with their period, hematology can help with platelet dysfunction testing. Sometimes we can consider a pelvic ultrasound when there is persistent abnormal bleeding that remains unexplained. And what we're looking for are structural causes for bleeding, such as fibroids and polyps. However, these would be very rare findings in the adolescent population. So let's move on to talk about how do we treat these heavy periods. So for acute management, so this is the patient that is coming in and has bleeding right now that we need to stop. The preferred method is to use a progesterone taper or a Provera taper. Now this is different than what we may have talked about before, or this might be different than what you've been using in the past, because a lot of people will use the combined OCP taper. And the reason why we prefer Provera over combined OCPs is because when you're using the combined OCPs multiple times a day, that's high doses of estrogen. And high doses of estrogen have undesirable side effects such as nausea, vomiting, mood changes, headaches. And then there's also contraindications to the use of estrogen that you also have to be aware of. So Provera kind of, you don't have to have all these undesired side effects, and the contraindication list isn't there. The preferred taper is to use 20 milligrams of Provera 3 times a day for 7 days. And this is followed by 20 milligrams of Provera daily for 21 days. You should expect that the bleeding should markedly slow or stop within 3 days of starting the 3 times a day dosing. And you may also see some spotting when you go from the 3 times a day to the daily dosing of Provera. At that time, you could choose to change over to a combined OCP, or if it's light bleeding, continue out this course. And then we'll talk about long-term management options in just a moment. Non-hormonal treatment of acute bleeding can be completed with tranexamic acid. You can use up to 1,300 milligrams 3 times a day for a total of 5 days. Often we use this medication if we're having refractory bleeding. And it's also important to note that this is an off-label use in adolescents under the age of 18. So for long-term management, this could be after you finish the acute management and have better control of the bleeding, or if the patient isn't actively bleeding, but we need to address their heavy periods, then we can talk about these long-term options. First, if there's an underlying cause of the bleeding, we treat that. And then afterward, we talk about these hormonal and non-hormonal choices. For one non-hormonal option is NSAIDs. So you can use ibuprofen starting the night before a period and continuing through the first few days of the period. This can reduce menstrual flow up to 80% and can help treat any dysmenorrhea or painful periods. Tranexamic acid is another option. Again, it's off-label use and similar dosing as for the acute management. And it's also cyclic. So they're only taking that medication or both of these medications when they're bleeding. What's more common to use are hormonal choices. So we have the estrogen and progesterone combined together, as well as progesterone only choices. So the estrogen and progesterone combined options are the pills, the vaginal ring, and the patch. When using the combined oral contraceptive pill, we recommend that you use at least a 30 microgram ethinyl estradiol and a monophasic pill. So these are a few examples. Sprintec and Janelle are options that would give a monthly cycle, where Seasonique would be an every 3-month period. You can take the pills as a cyclic, giving your period every month, as an extended cycle, giving a period every 3 months, or continuous dosing, which would be attempting to become amenorrheic or make the period completely go away. I will note that when you try to do these longer times and try to get the period to go away, There will be episodes of breakthrough bleeding, and when you have bleeding lasting more than 2 days, we recommend stopping the pill for 3 days and restarting on the 4th day, whether you're bleeding or not. Over time, these episodes of bleeding will become farther and farther apart and help to reduce menstrual flow. For the vaginal ring, you can use this cyclically, so giving a period every month, or continuously. If you're going to use it continuously, I just instruct to change it out on the 1st of the month because it's easy to remember. The patch you can do as well as a cyclic or continuous option. I will caution continuous use with the Xulane or the Ortho Evra patch, just because that has a higher dose of estrogen and it's more consistent with a 50 microgram oral contraceptive pill. So if that's the patch that you're using, then I would recommend only using that one in a cyclic fashion, giving you a period every month. And if you're wanting to use something more continuously, it might likely be safer to use a newer, lower dose patch called Twirla. And that is more consistent with a 30 microgram pill. Moving on to our progesterone only options, we have multiple different progesterone only pills, the Depo-Provera, the implant, and then the IUD. So for progesterone-only pills, you have Agestin and Provera, and I will note that these are not contraceptives. So Agestin and Provera are not a contraceptive, and they are there to help with menstrual suppression. You would take the pill daily and attempt to try to get the period to completely go away. Agestin, I would prescribe at 5 to 10 milligrams a day. I would caution use of more than 10 milligrams daily for long-term situations. They should have period control with the 5 to 10 milligrams. The reason why I caution using more than 10 milligrams a day for long periods of time is because there have been some small case studies that have shown an increased risk of liver hepatic adenomas with higher dosing. And that is mainly because there is this peripheral conversion of agestin to estrogen. Provera, typically we can get good control with the 10 to 20 milligrams daily. If your patient is also needing contraception but still would like to use a progesterone only pill, then the Micronor or Solend would be options. The difference mainly, other than the progesterone in the pill, would be the way the pill pack looks. So for Micronor, it's only active hormone pills, so you're trying to skip the period completely, where the Solend, it has a 4-day placebo pills in the pill pack, so you can choose to either skip those and take it continuously, or to give yourself that period every month by taking those placebo pills. Other options, again, would be the Depo-Provera, the Nexplanon, and the IUD. If you're looking for contraception and good menstrual regulation, I would recommend a LARC, so the Nexplanon or IUD. It is notable that the Nexplanon does have more irregular breakthrough bleeding associated with it, and so educate your patients about that. And you may also need to supplement with a progesterone only pill with that implant in order to get better menstrual suppression. So let's go back to our patient and our case that we presented at the beginning of the presentation. So this was a 13-year-old. She has irregular periods. They're happening within the regular interval between that 21 to 45 days. They're lasting 7 to 8 days, so a little bit on the longer side. Her flow is requiring 5 to 6 pads a day, which is again on the heavier side, but she doesn't have overflow at night. Her clots that she's passing are smaller than an inch in diameter. There's nothing in her history that concerns me for a bleeding disorder. There's no family history of bleeding disorders. Her vital signs are reassuring. And so the most appropriate first-line labs for this patient would be that basic workup. So we just start with the CBC, the ferritin, and thyroid studies. So when those results come back, If they show that we have just a mild anemia, hemoglobin's 11, her ferritin is low, and her thyroid testing is normal, our next step would be to look at long-term management. We have all those choices that we previously discussed, and then I would also add a multivitamin with iron because of her low ferritin. We like to see ferritin at least at a 30 or above. If results return and show that she had a moderate anemia with a hemoglobin under 8 or about 8, and her ferritin was low at 4, and her thyroid testing was still normal, then we would want to look at getting more of an extensive bleeding workup. And that would just be because her hemoglobin is under 10. This would be adding coags and checking a von Willebrand panel. If she's actively bleeding, then we would look at the acute management options in addition with iron. And if she's not actively bleeding, then we would look more at those long-term management options also with the addition of iron. And so that is all that I have. I hope that this was useful information that you'll be able to take with you to clinic. It was a pleasure presenting today. Thank you for having me, and I'm open for questions.
Okay. Kim, I'd just like to ask if you have any particular combination oral contraceptive pill that you like to use when you're treating people with heavy periods.
My go-to, and I think this is a bit more because of my training and background, is if we want to try to suppress the period and take a pill continuously. I think that the seasonal, because it's already coming in a 3-month packaging and there's less placebo pills. Otherwise, I do think that norethindrone as the progestin works well. And so that would be more of a Janelle or a Blizovi, and that's the 30 microgram, 1.5 milligram of norethindrone. Those are my two go-to pills that I will use for heavy bleeders.
Great. Thank you very much for your presentation.